Welcome everyone to today's presentation on common ENT problems in primary care. We are FMS from PKD Sabak Bernam, Selangor. Our goal is to provide an in-depth understanding on common ENT conditions, their causes, symptoms, and effective treatment strategies. This session is designed to benefit healthcare professionals and anyone keen on improving patient outcomes in ENT care. Welcome everyone to part 2 of common ENT problems in primary care. Previously, we had completed part 1, which focused on common ear problems. Now in part 2, we will focus on common nose and throat problems in primary care. Let's begin with the common nose problems first. Let's begin with the outline of this presentation. For each section, we will discuss clinical features, diagnostic methods, and evidence-based management practices. By the end of the session, you will have a clearer understanding on ENT workflows and treatment protocols. The anatomy of the nose involves both external and internal structures that play important roles in breathing, smelling, and protecting the respiratory system. Externally, it consists of nasal bridge, nostrils, nasal cartilage, and nasal tip. The internal nose includes the nasal cavity, which filters and warms the air, the septum, the nasal passages are lined with mucous membranes, and the turbinates to help regulate airflow. Lastly is the sinuses, which reduces cowway and affect voice resonance. Let's start with allergic rhinitis. Allergic rhinitis is a common condition caused by presence of IgE and a personal or family history of atopy. Symptoms include paroxysm of sneezing, rhinorrhea, nasal obstruction, postnasal drainage, and itching of the eyes, nose, and palate. Diagnosis is reached through a history that includes risk factors, characteristics of symptoms, physical examination, and, if indicated, confirmation of IgE presence. This diagram illustrates the pathophysiology of allergic rhinitis to help you better understand it. The ARIA classifications categorize allergic rhinitis based on duration and severity. By duration, intermittent symptoms occurs for less than 4 days per week for less than 4 consecutive weeks. Persistent symptoms occur for 4 or more days per week and persist for 4 or more consecutive weeks. By severity, mild symptoms do not interfere with daily activities, sleep, work, or school. Moderate to severe symptoms disrupt sleep, daily activities, work, or school performance. These classifications help to guide diagnosis and management by linking symptom pattern with their impact on quality of life. Here is the list of allergens that may trigger allergic rhinitis. Avoidance is recommended for certain patients. Assessment of allergic rhinitis involves identifying symptom pattern, chronicity, and seasonality, as well as evaluating response to previous treatment. Checking for coexisting conditions like asthma or eczema, and review environmental and occupational exposure to allergens or irritant. Identify triggers such as weather changes, odors, or smoke, and assess the impact on quality of life, including sleep and daily activities. Review medications, noting any that may worsen symptoms, and explore family history of atopy. Lastly, consider social factors, including housing condition, pets, and lifestyle to identify additional triggers. Examinations are as follows. During the inspection, observe for reduced nasal airflow or mouth breathing, which are common signs for allergic rhinitis. Additionally, check for a horizontal nasal crease across the nose dorsum, often associated with severe cases. Anterior rhinoscopy should be performed to examine the appearance of the nasal turbinates. Note whether purulent secretions are present or absent and assess for nasal polyps. Yellow submucosal nodules with a cobblestone appearance may also be observed, which could suggest sarcoidosis. These thorough examinations helps to confirm the diagnosis and identify any related conditions. For other investigations, allergic-specific testing, blood or skin tests, is not required for diagnosing allergic rhinitis or starting treatment. Most primary care doctors diagnose and treat allergic rhinitis based on symptoms and patient history. Testing may be considered if symptoms are not well controlled. Management of allergic rhinitis involves allergen avoidance as the primary step to prevent symptoms and reduce medication use. For mild intermittent symptoms, second-generation non-sedating antihistamine, oral or intranasal, are recommended. Persistent symptoms or those affecting quality of life should be treated with intranasal corticosteroid with the option to add a nasal decongestion and intranasal antihistamine if needed. For severe persistent symptoms, combine intranasal corticosteroid with oral or intranasal antihistamine, leukotriene receptor antagonist, or intranasal chromoline. If symptoms persist despite treatment, refer to an ENT specialist. What are the indications of referral to ENT? Number 1, children with asthma and suspected food allergies who are at higher risk of severe reactions. Number 2, people with suspected occupational rhinitis or asthma. Number 3, patients who do not respond to a standard treatment given by primary care. Allergic rhinitis in specific population. Among the asthmatic population, 30 to 40% of people with AR also have asthma, and most people with asthma also have AR. People with AR are 3 times higher, more likely to develop asthma. However, if AR symptoms improve over time, asthma symptoms also improve as well. All patients with AR should be checked for asthma. Among the pregnancy population, rhinitis affects at least 20% of pregnancies and can start at any time during pregnancy. It is helpful to reassure patients that pregnancy-related rhinitis usually goes away on its own. Regular nasal rinsing may help. Nasal sprays like fluticasone and budesonide are generally safe during pregnancy. Chlorpheniramine, loratadine, and cetirizine may be added, but decongestion should be avoided in pregnancy. Next, let's move on with rhinosinusitis. These are the definitions you should be able to differentiate in rhinosinusitis. Generally, rhinosinusitis is a common condition characterized by inflammation of the mucosa in both the nasal cavity and paranasal sinuses. Acute rhinosinusitis is when the symptoms worsen after 5 days or persist for more than 10 days but less than 12 weeks duration. Chronic rhinosinusitis is when the symptom persists or worsens for more than 12 weeks duration. And finally, common cold or acute viral rhinosinusitis is when the symptoms occur less than 5 days duration. Understanding these definitions helps in differentiating between the types of rhinosinusitis for proper diagnosis and treatment. The causative agents of rhinosinusitis can be viral or bacterial. The majority of acute rhinosinusitis cases are viral, with only 0.5 to 2% complicated by bacterial infections. If a patient presents with at least 3 of the following symptoms or signs, bacterial infection is likely. Number 1, discolored discharges or purulent secretion in the nasal cavity. Number 2, severe local pain with unilateral predominance. Number 3, fever greater than 38 degrees Celsius. Number 4, elevated ESR or CRP. Number 5, deteriorations of symptoms and signs. For acute rhinosinusitis, the common bacterial pathogens include strep pneumonia, Haemophilus influenza, and Moraxella catarrhalis. For chronic rhinosinusitis, the bacterial pathogens may include Staph aureus, Enterobacteriaceae, and Pseudomonas. For predisposing or risk factors of rhinosinusitis, acute smokers with concurrent allergic rhinitis are at higher risk of CRS. Both current and past exposure to secondhand smoke also increases the risk of chronic rhinosinusitis. A positive family history, family history of asthma, especially in the presence of CRS with nasal polyps, can contribute to the risk. Other risk factors include allergies, chronic bronchitis, emphysema, acute rhinosinusitis, chronic rhinitis, gastroesophageal reflux disease or GERD, sleep apnea, and adenotonsillitis. Clinical diagnosis of rhinosinusitis in adults involve inflammation of the nose and paranasal sinuses with at least two symptoms. One of it must be nasal blockage, congestion, or discharge. Additional symptoms include facial pain or pressure and loss of smell. Diagnosis is supported by findings such as nasal polyps, mucopurulent discharge, or edema in the middle meatus on endoscopy, or mucosa changes by CT imaging. A history of chronic rhinosinusitis should also be considered. For physical examination, anterior rhinoscopy is an essential examination for evaluating acute rhinosinusitis and should be performed in primary care settings. The findings observed during the physical examination can be classified into stages: normal mucosa, moderate, characterized by mucosal edema and mild inflammations, severe, marked by purulent discharge and significant inflammation, and obstructive, involving nasal polyps and anatomical blockage. However, for chronic rhinosinusitis, nasal endoscopy is more valuable diagnostically than anterior rhinoscopy. For investigation, nasal endoscopy is an important diagnostic tool. Nasal swabs for culture are generally not recommended for rhinosinusitis but may be considered in patients with acute rhinosinusitis who do not respond to antibiotics within 72 hours. Plain radiographs are not useful for diagnosis. A CT scan is recommended in cases of failed medical therapy, planned surgery, or atypical severe disease such as unilateral symptoms, blood-stained discharges, eye displacement, or severe pain. Let's discuss in detail the management of acute rhinosinusitis in primary care settings. Acute rhinosinusitis requires at least two symptoms, one being nasal obstruction or purulent greenish nasal discharge, with or without facial pain, headache, or smell disturbance. Acute bacterial rhinosinusitis, or ABRS, suspects if there is three or more of the following are present. Number 1, fever more than 38 degrees Celsius. Number 2, discolored mucus. Number 3, double sickening. Number 4, severe local pain. And number 5, raised ESR and CRP. If the ARS symptoms last less than 10 days, treat as acute viral rhinosinusitis with symptomatic care. If symptoms worsen after 5 days or persist beyond 10 days, it is likely acute viral rhinosinusitis. Provide symptomatic treatment and avoid antibiotics. If ABRS is suspected and the patient has 3 or more episodes per year, consider antibiotics. If no improvement, refer to an ENT specialist. Immediate referral is required for the following cases: periorbital edema, displaced globe, double vision, ophthalmoplegia, reduced visual acuity, severe headache, frontal swelling, signs of sepsis, signs of meningitis, and neurological symptoms. The antibiotic of choice for rhinosinusitis: for adult, the preferred antibiotic is amoxicillin or augmentin for 5 days. Doxycycline is the alternative choice. For children, the preferred antibiotics is amoxicillin and the alternative is cefuroxime. Antibiotics should not be used routinely in chronic rhinosinusitis. For supportive treatment, intranasal corticosteroids are recommended for rhinosinusitis with a treatment duration of 14 to 21 days for acute rhinosinusitis and 16 to 52 weeks for chronic rhinosinusitis. Short-term oral corticosteroids are reserved for chronic rhinosinusitis and should only be prescribed at ENT center. Antihistamines are prescribed for rhinosinusitis with symptoms indicative of allergy rhinitis such as sneezing, nasal itchiness, and nasal obstruction. Other medications like saline irrigation is beneficial for symptom relief. Analgesics may be used for pain management. Decongestants can be prescribed but should be limited to topical use for no more than 2 weeks to avoid rebound congestion, while oral decongestion require cautious use. Mucolytics otherwise have no proven efficacy in rhinosinusitis. Management of chronic rhinosinusitis begins with confirming the diagnosis through a thorough history and physical examination. Initial treatment involves prescribing topical steroids and nasal irrigation. After 4 weeks of therapy, the patient's symptoms should be re-evaluated. If symptoms improve, the current treatment should be continued. However, if there is no improvement, the patient should be referred to an ENT specialist for further evaluation and management. Indication for referrals in chronic rhinosinusitis. For early referral, which is within 2 weeks of duration, is recommended for patients who have failed a course of optimal medical therapy, experienced more than 3 sinus infections per year, or have suspected fungal infections, granulomatous disease, malignancy, or immunodeficiency. Urgent referrals within 24 hours of time is necessary for patients with severe pain or swelling in the sinus area, particularly those who are immunocompromised, such as individuals with uncontrolled diabetes and stage renal failure or HIV. Next, let us move on with epistaxis. Epistaxis affects 60% of the population, with 10% requiring medical attention. It is common in children under 10 years old, often due to nose picking, and in adults aged 70 to 79 years old. Anterior epistaxis accounts for 90% of cases and involve the Kesselbeck plexus. Posterior epistaxis otherwise involve branches of the internal maxillary artery, is less common but more difficult to treat. Epistaxis can result from local or systemic causes. Local causes include trauma, dry air, nasal irritation, infections like sinusitis, tumors, or nasal polyps. Systemic causes include hypertension, blood disorders, medication like anticoagulants, liver disease, and alcohol use. Assessment begins with a detailed history, including the duration, frequency, severity, triggers, associated symptoms, and medical history. Physical examination involves inspecting the anterior nasal cavity for bleeding points, crusting or lesions using the nasal speculum, and checking the posterior pharynx for signs of posterior bleeding. The immediate management of anterior epistaxis involves the following steps. Number 1, positioning. Calm the patient and have them sit upright with their head slightly forward to prevent blood from flowing into the throat and airway. Number 2, compression. Pinch the soft part of the nostrils firmly together for 10 to 15 minutes while the patient breathes through their mouth. Number 3, clear the nasal passage. Evacuate or remove clots, which may allow better visualization and promote clotting. Number 4, apply vasoconstrictors. If bleeding persists, apply a topical vasoconstrictor, for example, oxymetazoline or adrenaline, using a cotton swab or nasal spray. And finally, number 5, if bleeding still persists, referral to ENT specialist is indicated for cauterization and nasal packing. For management of posterior epistaxis is often managed by ENT team. Upon early assessment, whenever there is evidence of posterior epistaxis, immediate referral to ENT is required. Procedures that can be offered by ENT, such as cauterization, balloon catheter, and embolization, depending on location and severity of epistaxis. We have come to an end of our lecture. the common ENT problems in primary care. We personally hope this lecture would bring benefit to you. Thank you for listening.